Let me. And good evening, everybody. So today I am privileged to introduce an eminent person, um, Dr. Frank Ferris. So he's the Executive Director of Palliative Medicine at Research and Education, Ohio Health in Columbus. And he is also a clinical professor voluntary in the Department of Family and Preventive Medicine, University of California, San Diego School of Medicine, and an assistant professor adjunct Department of Family and Community Medicine and member Joint Center for Bioethics, University of Toronto, Canada. And he is also a recipient of 2005 CHPCA Leadership Award in recognition of his outstanding contributions to the field of hospice palliative care in Canada. And he is also a consultant at the International Palliative Care Initiatives Network Public Health Program, Open Society Institute, New York. And he is a board member at the International Association of Hospice and Palliative Care. And he is also the co-principal of education on palliative and end-of-life care, that is EPEC. And moreover, he is a great human being. And I had the privilege to meet him personally at Florida. And he's a teacher and he has been coming to India to teach in various programs. And I think recently he has been to International Association of Indian Association of Palliative Care Conference, which was held at Bangalore. So once again, it's my privilege, Frank, to welcome you to this session. And I'm sure he is going to deal with a session that all of us would think of what is there new in this session. We are dealing with this every day. But I am sure Frank is going to tell you something which is going to touch you personally. So, Frank, welcome you, and it's over to you.
Well, thank you very much, Sunil. Can you all hear me okay? Yes?
Yeah.
Yes.
Perfect. All right, so let me just share my screen. Just delighted to be with you, and thank you for the honor of your invitation. It makes it so much easier if you have your screens on, because it's fun to interact with all of you. So if you would turn your videos on, that would be terrific. What I'd like to do is talk about what I think is one of the most important topics that gets ignored in healthcare, which is the last hours of living. You know, we spend so much energy celebrating the arrival of a new child who has no history, but we get excited about it. But we don't get very excited about saying goodbye to somebody who's had an amazing history, when we should be celebrating the life of the person who has been and who will finish their life with us. So let's talk a little bit about the last hours of living. You know, the reality is less than 10% of us will die suddenly. Most of us are going to have a prolonged illness experience. In that illness experience are unique opportunities, but also risks if we don't get it right. What we hear from people over and over again is they don't fear being dead. What they fear is the dying process. And most people have this exaggerated experience of what dying is going to be like because of the media. But it's not like that at all, is it? You and I know that. So first of all, I'd like to start off with preparing for the last hours of life, because as a pulmonologist looking after a patient for a long period of time, that's something you can definitely do, is look after and help the person prepare for the end of their life. I'd like to introduce you to Jamie Brown, who's going to be interviewed on video by a colleague of mine, Charles Van Gunten. You could see what she was like in life as a school teacher, vital, full of life. She loved life. And then she got what she thought initially was a shoulder injury, but it actually turned out to be advanced amyotrophic lateral sclerosis. And Charles is actually interviewing her at her request. She wants to tell her story very close to the end of her life. Let's listen. We're going to see several short interviews. Let's listen to Jamie.
Well, I have to intensify. I have to focus on quality rather than quantity. Kind of cut to the chase. I feel like I've become blunt, excessively blunt, maybe, and I don't have time to waste.
I've become blunt and I don't have time to waste. I've got things I need to do. So the question becomes, what should we be helping our patients complete before they die? Do you have a comprehensive list? Do you help people with their advanced care planning? Who's going to make the medical decisions if Jamie's not able to do that for herself, if she loses capacity? And what does she want her care to be like? You know, I know in India there's a challenge with ventilators, but does you really want to be on a ventilator? Or would you rather I avoid that at all? And then if you're on a ventilator, do you want me to stop it if I can't reverse your illness? A lot of people would say, yes, absolutely. What about the finances, the bank accounts, the business power of attorney, the will, the guardianship, social issues? What about dependents and pets? Those reminiscence, the rites, the rituals, the prayers, the opportunity for people to remember what life has been like and celebrate the person. And then, of course, there's the whole issue of where am I going to die and what will my care look like? For Jamie, that was a huge issue because she needed care 24 hours a day, 7 days a week. She couldn't look after herself. And then for many people, they want to think about their funeral, their memorial service. Now, I know within Hindu tradition, within Islamic tradition, there are particular traditions that need to be followed. How do we make sure people don't miss those opportunities? And of course, for everybody, there's an opportunity for body and even organ donation. And even with metastatic cancers, an opportunity to donate cornea as long as it's not melanoma. Are we giving people that opportunity to give the gift to somebody else? And maybe you've got a digital footprint today, do you? How many of you have social media accounts? Many of us have Facebook, we have bank accounts, we have emails. Who has your passwords? Who has your login information? We need to talk to people about this because the reality is when you die, this all becomes frozen. It's out there. Facebook is going to become the largest graveyard in the world by 2050 because people's accounts are frozen and nobody can access them. So I personally have an if I die file and it has all my login information. It's a challenge to keep it up to date, but it's really important. And what about that opportunity for people to say goodbye? Ira Byock has talked for many years about the need for the person who's dying to say to the family, I love you. I hope you love me. I forgive you. I hope you forgive me, and goodbye. Profound words. And from my own personal experience of my partner dying, being empowered to live my life, I will always love you. I hope you will never forget me. My partner said, please find a new partner for your life and have a very successful life. And that was in 1990. a long time ago. But in the experience of losing a loved one, a partner, a wife, a spouse, a husband, do people get stuck in the I'm still married? Or do we empower them to move on and have a new life? That's so important. Now, of course, there's this issue of fear of dying. Was Jamie afraid? Let's listen.
You know, I really don't fear death because of my faith. I believe that if I can get through this hard part, then what's going to come next is going to be more incredibly amazing than anything I could imagine. And even I don't have words to try to describe that. But what I am afraid of is getting from here to there.
So again, back to that, are you afraid of dying? Yes, the process, but not being dead because of my beliefs, my spiritual perspective. So important. So how are you and I gonna manage the getting from here to there? Managing the dying process becomes core to our skills. I'd like you to listen to this video. It's a short one again. Alice is dying of aspiration pneumonia. Listen for the signs of the dying process and listen for the issues that you and I need to manage during the dying process.
She's just not even responding. She's just been laying here. She's been sleeping all day long, and she made some kind of weird noises in her throat. It just really scared me.
I understand. So what I understand you to say is that over the past few days that she's been weaker
Yeah.
and that she's been sleeping more, although she's had periods when she's been awake and she's been able to eat and drink a little bit and take her medicines. But the day that you haven't been able to wake her up.
And her hand, I mean, her hand has just been like really cold.
Well, I noticed the changes in her hands too. I noticed they're more cool and they're a little bluish. When I feel her pulse, it's quite weak. It's very thready. And when I watch her breathe, I see that it's very shallow. You notice it's just very gentle. So I think what I'd like to do is examine her, and then maybe you and I and Maureen can talk about what I think is going on in the living room. Would that be all right?
Okay.
Well, Melissa, Maureen and I came over because of the changes in your mother. And Maureen's been your hospice nurse for the last several weeks. I'm wondering what you're making of what we're seeing with your mother today.
I don't know, I feel kind of confused. Because I thought that she would just keep going on the way she has been, but now she really seems different, like things aren't right. I'm kind of worried, you know, if she can't eat, then she's going to just get worse, and I don't want her to just get worse, so, I mean, maybe we need to give her, you know, an IV or something like that.
We could do an IV, but I don't think it would make her better.
I thought maybe you would say something like that.
Did you?
Yeah.
Melissa, I'm afraid your mother's dying. I'm not sure exactly, but she may be dying in a day or two.
Like that soon?
It could be.
So no matter what we do now, it's not going to help?
No, I don't think anything we can do can stop her from dying. With the changes that we're seeing today, the changes in her breathing, the changes in her hands, makes me think that our body is shutting down.
What can I do to help her?
Well, I think it's important for you to remember that there's a lot of things that you can do for her. And some of them you've already been doing. You've been keeping her mouth clean with the swabs that you've been using. And you've been making sure that her skin stays clean and dry. And you're going to continue to do those things. You can turn her on her side and put a pillow at her back for some support. And that will help some of the secretions that you've been hearing in her throat drain out So I think it's important for you to know that you're doing all the right stuff.
Okay. I thought that I would have more time with her or something, I guess.
That's the way many people feel. It's never the right time.
Yeah.
As Maureen said, you've been taking a wonderful job taking care of her.
Mm-hmm.
As you know, she said that she wanted to be comfortable and she wanted to die in her own home, in her own bed. And you're helping her do that.
Is she in any pain?
I don't see any signs of pain.
Okay.
I think if she seems like she's in pain, if she's grimacing, you can still give her some of the liquid pain medicine just inside her mouth, inside her cheek.
Will people help me with this?
Well, I can contact the social worker at hospice and he can make some phone calls, and we can certainly get some caregivers in here to help you out. That way you can just continue to be her daughter, loving her and not giving her 24-hour care.
Okay.
So I agree with Maureen. There are many things that we can do for her right now. I think she can hear you. I think she can feel your touch.
Mm-hmm.
Most people are afraid of dying alone and dying in pain. I think you can assure that neither of those things happen to your mother. That's a lot.
Okay.
What other questions do you have for us?
I guess just to know that you'll be there.
I may not be able to see your mother again before she dies. You can certainly get me by phone, and Maureen can get me by phone. But the hospice team is going to be able to be here to help you and your family through this. I'll be sure to give you a call, and so we can follow up.
Okay.
Okay?
So I hope what you can hear in this brief interview is the complexity of the issues that we need to address as we enter the dying process. It's not just the person is unwell. We actually see signs of the dying process, and we make a new diagnosis. It's not just that change in consciousness, but it's the associated changes in breathing patterns, the loss of ability to swallow, and the absence of gag reflex, if you test, the buildup of secretions. Maybe it's the change in mental status, the delirium. Maybe it's loss of sphincter control. Or is it the cardiac output failure that may even lead to the renal failure? Now you'll notice I've highlighted changes in breathing patterns, loss of swallow and gag. If these are new, these are pathognomonic and diagnostic that the person is now really dying. And of course, you as pulmonologists would recognize these different types of patterns. Sometimes they occur much earlier in the person's illness experience. Let's unwrap all of this. And I might just comment, sometimes my microphone sound gets garbly. If it does, please just tell me and I'll fix it. There's also a series of issues that we need to manage. The weakness, the fatigue, the change in appetite, the cutaneous ischemia that can lead to skin breakdown, that cardiac and renal dysfunction that can lead to buildup of toxins, the neurological changes, the pain, and people get really startled when people can't close their eyes. We need to understand why. So let's unwrap each of these. The first is to recognize that you and I, as we approach the end of our lives, are likely going to be weaker and fatigued. We're not going to be able to move easily. We're going to need help with our activities of daily living, the bathing, the toileting, the feeding, the transferring. Now, what we know is as people go to bed, it doesn't change the proprioceptive neurological system, which has sensors in our joints and our muscles, which are designed to warn us and get us to move. People get really painful and achy muscles and joints. If you haven't done it, I suggest you lie in bed for half an hour and don't move anything. I bet you can't do it without getting very uncomfortable. So what we need to be doing is teaching the caregivers passive range of motion, keeping somebody moving. And of course, we need to make sure we're turning them routinely and providing massage to reduce the risk of pressure ulcers. I'll come back to that a little bit later. There's that decreasing nutrition and fluid intake, which distresses everybody, because of course, aren't fluids and nutrition a sign of love? People have been feeding each other for years. And now you can't eat? Oh my goodness, does that mean you're going to die? Are you giving in? What you and I need to remind ourselves and them is that food can actually become nauseating. The anorexia leads to ketosis, and one of the ketones is actually an anesthetic agent. It can be very protective. And of course, there's a risk of aspiration. I don't know whether you've ever had that happen to your patients, but I certainly have, and it's awful. This particular family, I'm thinking about the son who was 24 years of age, who'd given his father some yogurt, which he's aspirated, and his father died, thought he'd killed his father. It was horrible. So what I say to people, if the patient has their teeth clenched, it's their last way of exerting control. Don't push. What you and I need to do is teach the family how to do this. We need to talk to them about small plates, small quantities, preparing person's favorite foods, or maybe not at all. We need to tell them that patients who are not drinking, and many of our patients still have a lot of fluid on board, some of them even have peripheral edema, while they're afraid the person will be dehydrated and thirsty, they may not be. Thirst is actually driven by a dry mouth. Again, dehydration by itself can be very protective, releasing endorphins as well as the ketones that may themselves be anesthetics. But particularly you and I need to, if somebody's got a dry mouth, manage the mouth breathing. We need to make sure that we're keeping the mouth moist and doing good oral care. I suggest Vaseline or another petroleum-based product could be one of those lip sealants to protect the cracking in the lips, and using a baking soda mouthwash to moisten the mouth. Now, of course, there's that decreased cardiac output, isn't there? And you and I need to recognize that as the volume of urine goes down as a result of all of this, that parenteral fluids can actually be harmful, not helpful. And we need to recognize that when a patient gets below 500 mils of urine output, which is amber, or 250 milliliters of urine output, which is now dark brown, that fluids will go to the wrong places. And the worst wrong place, of course, is the alveoli. Now, many of our patients also have hypoalbuminemia, and that also means the fluids go to the wrong place. So what you and I need to be careful about is that we're not giving fluids in the face of hypoalbuminemia or anuria or oliguria. We need to be careful about the volumes. So how much fluid can you give? Again, you need to know the science of fluid loss, even in the face of no urine output. You and I lose through perspiration and respiration about 250 milliliters of fluid per day by each route, a total of about 500 milliliters per day. So you and I can safely, if the family insists on an IV, we can safely give 20 milliliters per hour. Most families are not watching and counting the drip rate. They're just happy that there is a drip. And so it becomes a bit of theater to keep the family happy and to make sure that we don't overload the patient. Now, clearly, if the patient still has some urine output, you can replace the urine output volume as well if you need to. But I would say if you don't have an anxious family, don't start an IV. You don't need it. Again, the ketones, the endorphin release can be protective. What we do need to do is keep the mouth moist, the nares moist, the eyes moist. I like a baking soda mouthwash. You can see it's 5 mils of baking soda with 5 mils of salt in a liter of water. Keep mouth moist. And use the Vaseline-based product to coat the lips and the nares. And use some ophthalmic lubricant that you could buy in the pharmacy to keep the eyes moist if they're open. So what about the neurological dysfunction? One of the experiences is loss of ability to swallow. And you can imagine for a patient with amyotrophic lateral sclerosis, this was a big deal. Let's listen to Jamie and hear what it was like for her.
Lots of times it's scary. I've had a lot of trouble with the mucus in my throat that is often present with ALS. And I heard about air hunger, that feeling of suffocation and not being able to breathe. And now I know what that's like, because lying in bed at night with my arms totally paralyzed and under the covers, I can still move my fingers a little bit, but I can't do much with moving my head, and I have to be able to reach the call light. So I've often been panicked and terrified when I feel that in my throat and I don't have the muscles in my throat anymore to either swallow it down or cough it up.
Often panicked. Now, I use Jamie because she tells her story so beautifully. And of course, she experienced this before she was dying. But can you imagine having some level of awareness, but you can't clear your secretions because you've lost your ability to swallow and your gag? Are many of our patients going to be panicked about this, but they can't express it because they can't communicate with us? You and I need to be very aware of this. So I remind you that this neurological function of our ability to swallow, our ability to cough, clear our secretions is coming from our cranial nerves. And what's happening if people are losing this ability is not only is cortex failing, but now our brainstem is failing, particularly at the level of medulla. This is a fundamental neurological function. Most of our secretions are coming up from our trachea and our lungs because, of course, fluids are constantly leaking from our vascular space into our alveoli, and we're constantly clearing them in life. Coughing, ciliary moving fluids up. These patients can't do that. So what we need to do is either postural drainage, turning them on their side, and I do that very frequently with my patients, to drain them out, to get rid of those secretions. We could just reposition people. What we know is suctioning is really not effective because it only goes into hypopharynx, and the majority of the secretions are much lower down, often beyond our larynx. Alternatively, what we can do is use medications to deride the secretions. One of the anticholinergics, maybe you've got glycopyrrolate, scopolamine, atropine, all of these can be very effective. The distinct advantage of glycopyrrolate is it does not cross the blood-brain barrier. It may not add to any confusion, whereas scopolamine and atropine both cross the blood-brain barrier as anticholinergics in the elderly, they could add to that change in mental status. Now, because these all have a half-life of about 8 hours, you can use bolus dosing, or you can deliver them by infusion. And again, what I will do is titrate to effect. If I'm giving it subcutaneously, I can give it every 30 minutes. I'll typically give a dose of 0.4 milligrams to start with. Some patients require more, and I combine that with apostol drainage to get rid of the fluids in the first place. And then I want to keep the secretions down. Now, of course, if somebody has a level of alertness, they'll hate the dry mouth that ensues. So you and I need to be pretty aggressive about the mouthwash and the Vaseline that we're using. Alternatively, we could use a scopolamine patch. Those are available in some settings, but they're low dose. You probably need 3 or 4 patches. Now, of course, breathing was also an issue for Jamie. Let's listen to her experience of changes in breathing.
I never thought that I would be using drugs like morphine, but it really does help. And it helps relax the throat muscles. It helps me to relax and not tighten up further, and the working muscles I have. It helps with pain. It helps put me to sleep.
So morphine works. What we know, again, is the breathing control center, which is again in our brainstem, is actually surrounded by morphine receptors. There are multiple in the region. Now, you and I get inputs that continue from our intercostal muscles, our diaphragm. We get inputs from our face, the whole cranial nerve area. We also get inputs in terms of the chemoreceptors. And if any one of them is out of balance, you and I are going to feel short of breath. Now, you could recognize when the change is occurring by these types of breathing patterns. And I will say that if Cheyne-Stokes respirations are new, it's absolutely pathognomonic if this patient is dying, just as the loss of ability to swallow and that loss of gag. Pathognomonic, this person is now in the process of dying. If we can't breathe, we can't swallow our secretions, we're not going to survive. Of course, there's a huge amount of fear around this. I don't know about you, but this is the thing I fear the most for my future. What we do know is that opioids in very low doses, 5 milligrams of morphine orally, equivalence is 2 milligrams subcutaneously or intravenously, is enough to settle most people's experience of feeling breathless. What we do also know is that oxygen won't necessarily help. If somebody is desaturating, it can be useful, but otherwise, what's the real effect? It's actually the flow. When people experience the air going across their turbinates, or even better, across their face. I don't know how many of you have actually been on a plane flying. Did you reach up and open up the air so that you could get the airflow and then you felt more relaxed? We have clear evidence that using a fan and simply circulating the air is more effective in most patients than actually spending the money on oxygen. Now, I do want to finish this off by saying Jamie wanted to tell her story. Everybody thought she was going to live for quite some time, but because she'd said her story, she died, quotes, unexpectedly, even by her nurse and physician a week after the interview. Again, people have a story they want to tell, and when they've told it, they often let go. So how can you and I facilitate this? It's important to focus on the reminiscence, the storytelling, getting the people to the bedside will really make a difference for the patient and allow them to let go. Now, what else do you and I need to focus on? Well, of course, patients in the process of dying, they have changes in their neurological function, altered mental states, and they may get terminal delirium. I really like this particular diagram coming out of a paper many, many years ago. It really illustrates that people die along two different pathways. Fortunately, the majority of patients go down this, what I would call the usual road. I'm going to say in my experience, it's 70 to 80% of patients. And that's a hypoactive delirium. Please label it. As doctors, you and I need to use the words delirium, and whether it's hypoactive or hyperactive, or maybe it's mixed, put it in the chart. It's not a nursing diagnosis. They will say anxious, irritated. Of course, this is the patient on the usual pathway that nurses love, the quiet sleeping patient who wakes up intermittently. But as we know from interviewing patients who've had a hypoactive delirium, their suffering can be profound. Hallucinations, nightmares, bad dreams. Again, it's important to recognize that the part of our brain that hears is different from the part of our brain that processes information, is different from the part of our brain which allows us to express information and reach out. It's the expression which goes away first, but the processing may continue and the listening may continue. So even when the patient's on the hypoactive pathway, we need to think about managing it because people may be suffering. Now, if they're on the hyperactive pathway, my experience, 10, 20, 30% of patients, just a rough estimate, this is not a happy place for the patient or the family or the caregivers or the staff. Isn't this when your staff in the hospital get really agitated themselves? Do something. So we need to do something. If it's a hyperactive terminal delirium, the difficult road, what's important is for us to settle the patient. Think about it. It's the patient who's moaning and groaning, maybe moving. We want to stop the phonation. We want to stop the movement. We want to make sure the person has amnesia. Oops, sorry. So what you and I want to use in this case, which is not indicated for normal delirium, benzodiazepines, the backup of barbiturates and propofol. And this medications to use and the dosing are on the palliative cards that I sent you for the irreversible delirium. Now, why benzodiazepines are particularly perfect is because they are anti-agitation, they do sedate, they're anxiolytic sedatives. Most importantly, they inhibit short-term memory production, they're amnestics, they relax skeletal muscles, and they will protect the patient, they're anticonvulsants. So particularly if we have patients with intracranial disease, it's important to make sure they don't have a seizure. Having a seizure at the last time in life, those last few hours, is an awful situation for everybody. Now, I put down the contrast with antipsychotics because, of course, using haloperidol or risperidone or olanzapine, quetiapine may be appropriate for us to use in the potentially reversible delirium. It's not going to help us here because it's not an amnestic. It doesn't relax those skeletal muscles, and those vocal cords are skeletal muscles. We want to relax them so we stop the phonation. And please, never, never, never use opioids to manage the delirium. The sedation from opioids are adverse effects. And in my experience, if you're using an opioid at the end of life for a patient who does not have pain, and you're titrating the dose, you'll actually make it worse, the delirium, make it worse. And this will be the fastest way for the medical examiner to be interested in looking at your charts and your practice. So don't do it. At the end of life, for the agitated delirium, benzodiazepines are the choice. I like to just use very low dose of lorazepam, or you can use any one of the complementary benzodiazepines. I give 1 milligram, pre-dissolve it in a bit of water, place it up against buccal mucosa. If I'm able to, I do this in the home all the time. Wait an hour. If not effective, I give another dose. If 3 doses ineffective, call the doctor and I double the dose. And then I need to recognize that lorazepam's half-life is 12 hours. So once I get control, I dose every 12 hours to keep at a steady state. There are no clearance concerns, so I don't have to worry about renal failure. I could also use midazolam. For time, I'm not showing you all the details. And here's my strategy for giving it against the buccal mucosa: taking out the plunger of a 3 ml syringe, putting the tablet in it, pulling up 1 ml of water, 1 ml of air, and shaking for it to dissolve, and then placing a glove finger and placing it in the buccal mucosal area, never passing fingers through teeth. Important that we teach families to do this. They can do it easily themselves. Now, of course, midazolam I could be using. Need to recognize it has a very short half-life, so now I need to dose it by infusion. Of course, I could use a bolus to get started. Now, of course, the question people say is, well, with these benzodiazepines, are you hastening the patient's death? And the answer is no. First of all, I'm trying to achieve amnesia, settle the confusion and restlessness. I don't care about the hypotension. It's a part of the dying process. And respiratory depression is just not an issue. We know the LD50 of all these medications. It's the lethal dose for 50% of the rats. And you need to know the numbers. They're huge. I told you I'm going to use 1 milligram or 2 or 3. Typically, it's anywhere from 2 to 10 milligrams of lorazepam to settle a patient. Midazolam, the most I've ever used for a compassionate extubation when the patient was naive to midazolam, is 10 milligrams. Most of the time, 5 milligrams intravenously is just fine. These are tiny doses compared to the doses of lethality. I am not hastening anybody's death. Now, what I showed you on the cards was when benzodiazepines fail, our backup is propofol and phenobarb, and the dosing formula are on the reference cards I sent you. If you need more details, we're happy to provide that, and I'm sure a palliative care provider in your community would be happy to help you with that. But I'll tell you, I've used propofol in my 35 years of doing palliative medicine. I've used propofol twice, and I've used phenobarbital probably 5 times. They were much earlier in my career, because today I think we don't see some of the horrible, horrible local disease we used to. Now, you may still be, in which case you may still be needing to use it. It's fine, no problem. The strategies are on the cards that I gave you. Now, what about that hypoactive, that quiet sleeping patient? Are they suffering? It's a good question. And it's kind of hard for us to know because they don't tell us unless they wake up for a bit. And there are some patients that wake up and say, oh, I saw grandmother coming to get me, or the puppy dog. It was all very pleasant. I'm not sure we need to treat those pleasant hallucinations or dreams. But if the patient is suffering, again, do I need to use a little bit of medication? If there are bad dreams, nightmares, hallucinations, paranoia, is that something that you would like to experience if you're dying? I suspect not. I'm certainly very clear. I don't want to experience the dying process. So let's ask our patients in advance, because we know delirium effectively occurs in 100% of patients. whether it's hypoactive or hyperactive. And you and I need to be prepared and find out if they want to experience the dying process. Now, I say this particularly because there are several groups, including Buddhists, who say, no, 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 I don't want medications. I need to experience crossing over. So we need to ask who wants to experience and who wants medications. So, of course, this is a profound question for us to reflect on, isn't it? Would we want to experience a hypoactive delirium if it's got bad dreams, hallucinations, nightmares? I'm clear I don't. What about you? Should I give you a low dose of benzodiazepine to ensure amnesia? I'm really clear. Yes, please. And a milligram or two of lorazepam or an equivalent of another. You can use alprazolam, clonazepam, any one of these. It'll do the trick. Keep me comfortable. I do not want to experience this. But of course, there's pressure from families, isn't there? What about communication with that unconscious patient? Well, again, I said it before. We need to recognize that people hear through one part of their brain, they process through another part of their brain, and they respond and communicate through another part. And the part that allows people to communicate with us is what fails first, but they may still be thinking and hearing and listening. So what I like to make sure is people understand this, the family, the caregivers, and that we include people in the communication. Good news at the bedside, challenging news behind a closed door somewhere else. Now, our anesthesia colleagues use the eyelash reflex or corneal reflex, but they use the eyelash reflex, most of them, to establish whether a patient's anesthesia is deep enough that they are unaware of what's going on. This is, again, a primary reflex in our brain stems, which allows, if we touch the eyelash, we get a flicker. When the eyelash reflex is absent, what we know is there isn't cortical awareness. So this can help us establish in the dying patient, is there cortical awareness or not? I'll even teach this to families. Well, look and see. If they have a reflex, you can assume there's still some cortical function. Afterwards, if there's no eyelash reflex, there's probably no intellectual awareness. So create that familiar environment, assume the patient hears everything, include them in the conversations. And of course, there's touch and music that can really make a difference. I've seen patient after patient over my career where they're unable to respond, but clearly they're taking in the information. Many are waiting for somebody to arrive, and you see them settle when the person arrives and often die at half an hour or an hour later. Or you hear a bad news conversation and people get agitated. The patient gets agitated. You can see them start to fidget. If you look at their pulse and their blood pressure, it changes. So again, they're probably listening. We don't know because they don't come back and talk to us. So it's then important for us to be able to say those goodbyes that Ira Byock described, to give people permission to die. And you and I may need to teach the family how to sit down and say, my dear one, it's okay if you die. I'm going to be okay. We've seen family struggling with this, but when they finally settle and they give permission, we see the patient often die a few hours or a day or two later. Again, we need to teach them the words of giving permission and saying goodbye. Of course, that's hard for people who are grieving. But can we get them there? That's the best of palliative care, because then people who survive, the family, will remember all of that. And it doesn't matter if you've done wonderful pulmonary care throughout life and you don't get the dying process right. People remember the bad dying. They forget about the really good care you provided. That's what sticks with them for the rest of their lives. But of course, there's the issue of pain, isn't there? Does pain get worse? I'm going to suggest to you, because pain is about perception in our thalamus and other parts of our brain, we have a fear that it's going to increase, but it actually probably isn't. And what we do know is that we should assess the unconscious patient. It's particularly here, the muscles are the last place to relax. And if I have constant grimacing or fleeting expressions, maybe I have pain, maybe. But of course, I can have gas and get that, or I can be having a bad thought and get that. If I see that, maybe an opioid is helpful. If I don't see that, don't use an opioid. The restlessness, the agitation, the calling out is probably the delirium, not the pain. Because I don't think that pain gets worse as people are dying. In fact, it stays the same or probably gets less because their perception changes. It's not as though the physiological inputs from the proprioceptors, whether it's the tumor or the arthritis or whatever, they don't change. In fact, they become less active as well. So it's important to differentiate between real pain and whether it's terminal delirium, which is very common. Now, what about the whites of a dying patient's eyes? What's that all about? What's the pathophysiology of that? Well, it's pretty straightforward. Most people think it's neurological. It is not at all. This is about the amount of fat behind our orbit. People lose the retroorbital fat pad. The orbit is being pulled backwards by muscles. We don't have enough eyelid to cover our eye. We grow our eyelid just to oppose, and when it goes back, there's not enough eyelid. So we see the whites, and in fact, neurologically, these people are often moving their eyes, so there's no light impacting on their pupil. So, of course, you and I need to be aware of dry eye. Ophthalmic lubricant becomes all important here, offering it every 4 hours to keep the eye moist, because a dry eye is horrible. Remember that if we're using artificial tears or even a contract lens solution, we get evaporation probably every 15 minutes, it'll dry out. Not helpful. You need an ophthalmic lubricant. But you also need to teach families why this is occurring. It's not as though the patient is suffering, as long as their eye is not dry. It's going to be fine. So what about turning patients? There's mythology out there that we should be turning patients every 2 hours. It comes from Florence Nightingale, who was the first nurse who described this, which was really about how long it took her to go around the ward and come back again. It's got nothing to do with the pathophysiology. Our skin will survive pressure and ischemia for very short periods of time. In fact, probably better that we're turning patients every 30 minutes, stimulating blood flow by massage, making sure we're doing that passive range of motion, pillowing people to reduce the pressure, and making sure they're on an appropriate closed cell mattress that's thick enough. What I like to say is, if you've got a mattress the patient is on, you should be able to put your hand underneath and feel at least 2.5 centimeters of foam that's compressible at the lowest point of the patient to make sure they're on enough pressure reducing foam. Many of the foams that we can buy in pharmacies just aren't enough for the patient. So we need to get family turning the patient regularly. And I like to get people turned every 30 to 45 minutes, still trying to minimize skin breakdown. And what about medication use? Well, most medications we're just not going to need, are we, at the end of life? In those last hours of life, it's a time to stop things. Please use the least invasive route of administration. You can use the buccal mucosa for morphine. You can use it for the benzodiazepines. It's fine. If you really need an infusion or an alternate route, please use the subcutaneous. You don't need the IV route unless the patient's already got IV access. And I don't like intramuscular at all because it's painful. You just don't need to do that. Administering medication subcutaneously works as well as intramuscular. And remember the kinetics. Medications by these different routes of administration take different times to be absorbed. And of course, if the person has cardiac output failure and things are slowing down in terms of blood flow, it may take a little longer. Subcutaneous is 30 minutes to get to Tmax, maximum effect, maximum risk of side effects. Orally, it's an hour. And even delivered buccal mucosally, morphine or the benzodiazepines are the ones I'm using at the end of life. It works. After about an hour, you start to see the patient settling. You can give another dose if they're not settled. And remember that the half-life of morphine is 4 hours, but you need to know the half-life of the benzodiazepines. It's 12 hours for lorazepam. For clonazepam, it's 30 hours. You got to look it up on the tables. And of course, understand the kinetics will be at steady state after 5 half-lives in terms of routine dosing. The other piece that I'd like to remind people of is if you're using morphine, and I know that's quite common, at the end of life, you need to be aware of the fact that morphine flows with the fluids. It is passively cleared in our urine. If we have urine volume output, out it goes. If we don't have urine output, which is what happens at the end of life, it isn't cleared. Now, morphine is broken down into 2 different metabolites by glucuronidation in our liver. And in my experience, unless we have profound liver failure, we're still producing the glucuronides. The morphine 6 is the analgesic. And as long as I have given it and I have it in my body, I have analgesia until the patient dies. What I don't want to do is give too much morphine, because you'll notice the morphine 3 is responsible for the excitation, the bad side effects that we don't want, which can include hallucinations, delirium, confusion, drowsiness, etc. I don't want to give more morphine and overfill the patient's tank. You know, from morphine's perspective, you and I are just a bucket of water. We put it in every 4 hours because we pee it out. If we stop peeing, we need to start putting it in. So what I like to say is if patients have less than 500 mils of fluid output in their urine, at least decrease the routine dose by 50%, or even stop the routine. If they have less than 250 mils, which is that dark brown urine, stop giving the patient morphine. They will still have morphine 6 glucuronide on board. They will have analgesia until they die. What we don't want to do is give them excess analgesic, because we'll give them morphine 3 glucuronide and we'll throw them into delirium. And before I understood this, we used to give excess morphine, and of course, people's delirium got worse and worse and worse. It was when we started transplanting patients that we learned all of this pharmacology, and we learned we really have to stop giving the morphine at the end of life. So what I want to finish off, and I'm happy to answer questions, and I see there are some in the chat. You know, everybody remembers what happens during the last hours of life. more than any other time, you and I need to get it right. So we need to focus there. So I'm interested in answering questions. Let's just go over to the chat and see what's happened. But I also am happy to have people turn on their microphones and ask questions. And I see Rajam's there. Greetings, Rajam. How are you?
I'm very good and always lovely to hear you talk, Dr. Ferris. I mean, every time I hear you, there is something new I learn on how I should teach the next set of people I address this very, very difficult and extremely important topic, which I think during our training, we missed out totally. Nobody taught us death and dying. One profession closest to dying, we were not even told how to talk, how to deal with it, and how to deal with our own emotions. So it's always excellent to listen to you. The one question which popped up, and I think which is important, is when do we initiate end of life, is one question asked by Dr. Suresh Kumar. And also the comment that culturally, the kind of people that you deal with is different from the kind of people we deal with. Unfortunately, despite one of the religious books in our country talking about life and death being the same side of a coin, still, when it comes to modern medicine, I think we are a death denying society, and people want to keep trying. And sometimes you can see patients and the caregivers face fall when we say that ICU treatment is futile, and they say, but how can we not give it? But we can afford it, because 80% of the care which is received in this country is private practice. Money dictates a lot of things. So it's odd when we say that if the patient can afford it, he actually ends up probably suffering more. And if the patient is poor, he probably still suffers, because not that he gets palliative care, but he doesn't go through unnecessary medical futile treatments. So culturally, I know it makes a big difference. From where you come, I think people are also more, I'm not saying more aware, but are more comfortable talking about death and dying, maybe, is what we feel. But I don't think people and human race is different in America or in India. I agree with that. I have realized that now. In the beginning, even I used to have this thought that it's difficult to talk to Indian patients and relatives, while it might be easier to talk to Americans. So over to you, Dr. Frank. One question was, when should we exactly start the end of life?
Well, so my talk, so the great questions, I love them. So my talk started out with preparing for the end of life. And we need to start that early, don't we? It's this, have you got everything in order? Have you thought about what you want? Some people get delirium at the end of life. It's asking the question, if you get delirium and agitation, are you somebody who wants to experience whatever happens as you cross over and you die? Or are you somebody who wants me to make sure that you're comfortable? Most people will say, give me the benzodiazepines, please. But we need to ask, because some people won't want those. So it's and the question I always ask is back to the cultural piece. And I'm going to come back to the when to start the dying in a second. But the cultural piece is, who's afraid of talking about dying? You and I weren't taught how to do this in our medical schools, in our residency training programs. Aren't we the ones who are afraid because we don't know what to say? And when we don't know what to say, we avoid the topic. One of the things you can ask people is, and again, as we go back to teaching communication skills, what are you thinking about? What are you worried about? What are you afraid of? And a question I like to ask people is, what do you think about at 2 o'clock in the morning? Are you worried about what's happening? It's a door opener for the question. And some people will say, am I dying? And what's it going to be like? And other people will just avoid the topic completely. So you don't have to say, have you thought about dying and what it's going to be like? But you can ask very open-ended questions and see where people take you. The other question you can ask is, are you seeing value in the treatments I'm giving you? Using, again, ask, don't do a tell, ask. See what the patient and the family perceive as happening. And then be able to be honest with the family and say, you're right, this is not helping, is it? And the therapy isn't doing what you and I are hoping for. I think that's so important, is for you and I to be able to say that. But at the same time, for us to be able to say, we are absolutely going to look after you, and we know how to look after you at the end of life. Because you heard Jamie say, I'm afraid of what the dying process is going to look like. What we said to her very clearly is, we will be with you and we know how to manage it. You don't need to be short of breath. We know the morphine helps. I don't anticipate your pain will be worse. In fact, I think you may not experience as much pain. If you get agitated and restless, I'm going to create amnesia. You won't know it's happening. I'm going to stop your thinking. And when people say, well, what's that? You can ask, well, have you ever heard of somebody who's had an outpatient procedure? Maybe it was a colonoscopy or some other kind of procedure, and they didn't experience it at all. That's what we're going to do for you. So it's trying to relate to something that the patient will know from maybe their experience or somebody else's experience. So there's this whole preparing, and then we start to see signs of the dying process. They usually come on slowly, one at a time, but often we see 2 or 3 of them. An altered breathing pattern. The person is now having some apnea, or maybe we've got some Cheyne-Stokes, or maybe the tidal volume is decreasing and they're getting tachypnea. Coupled with, ooh, they're not swallowing their secretions, are they? We diagnose this person is now actively dying. So they're in that next phase, that last phase, actively dying. Maybe it's the peripheral cyanosis, the cooling of the limbs. It's usually 2 or 3 things together that help us be able to say, this person is no longer just unwell, they're actively dying. And then we make sure we're looking after the secretions, we're managing the mucous membranes, the eyes, the mouth, the lips, the nares. We're turning people when they can't be turned themselves. We're looking after all of that. We've made that diagnosis. So when do we start all this? It depends on the issue. If a person is weak and fatigued and they're not showing signs of active dying, we still need to be turning them to protect their skin from breaking down. We need them on that pressure mattress. We need to be doing good skin care. If a person now has altered respirations, we're seeing Cheyne-Stokes respirations and loss of ability to swallow, they may be well into the process. We just need to make sure that from our perspective, we perceive that they're not experiencing shortness of breath. We perceive they're not restless and agitated. So
thank you for that, Dr. Frank. There's another question from Dr. Shahjahan. Again, something that pulmonologists face extremely often. Many chronic lung disease patients respond differently with severe respiratory dysfunction. Some even come out. So how will you decide not to have any further interventions? It is a real difficult issue. I agree with that. Over to you. And then I will like to add a couple of lines after that, because I have the experience of being the pulmonologist, and with the help of palliative care, I know now how to deal with this in an Indian scenario. But over to you, Frank, Dr. Frank first.
well, can I understand the question a little bit more?
So, suppose you saw many chronic lung conditions. For example, you have
Yes.
2 COPD patients, both have come with a pneumonia. One does well, both go on the ventilator.
Right.
One does well, one
Gotcha.
doesn't. So how do you know when to decide which is the one who's going to come out and which is not? So, and it's a difficult issue because sometimes patients do surprise us and they do come back, and we are also shocked. So why not offering him intensive care? Are you denying him something? Or how do we decide that? Correct, Dr. Shahjahan? Is that what you wanted to ask?
Yes, that's the thing I wanted to ask, because if I admit 10 patients, they're different in different ways, and even with a very severe issue may come out, a trivial issue.
Yes, over to you, Dr. Frank. I think his line is kind of frozen. So
Oh, there he is. He's
yeah.
back, so I can see him moving now. So, you ask us such an important question, and obviously We customize the care patient by patient, family by family. One of the questions we need to ask, and I think it's important that you and I ask it first, will this patient ever be the person they were before? You know, you and I, we get these assaults of, for example, a pneumonia on top of multiple chronic problems. Is this the way they want to live? Are they, after the pneumonia, going to look the same? When you say they come out of the pneumonia and they surprise us, how many of those people go home and live a normal life when they have chronic respiratory illness and now they get a major assault on top that needs them to be ventilated? How many of them truly go home and live a normal life? My experience is almost none. And if I get a patient, for example, the patient that I like to use for teaching about, do I even start antibiotics, let alone the ventilator, is the person who has dementia, the person who has underlying cancer. He had some heart failure to start with, some chronic pulmonary disease, because they all go together. And now he's got pneumonia and he's unresponsive. You got to be able to cough. You got to be able to do things. You got to be able to understand commands to really get better. I wouldn't even start antibiotics in this patient, let alone put them on a ventilator. This person is never going to survive. They can't get rid of all the debris that's in their pulmonary tree. So it's all contextual, isn't it? You and I have to look at the person. What was the baseline from which they started? And of course, some people get a little better. Is that the way they want to live? And who are we doing it for? Are we doing it for the patient? Or are we doing it for the family? And are we really addressing the family's distress at the impending loss? How many of you say to family, let's say it's mother, you love mother very much, don't you? This is to the family. You want to protect mother and provide the best possible care. And you're afraid of losing mother, aren't you? Because, of course, mother is a primal relationship, isn't it? Every one of us came from our mothers. And we never want to lose mother. And we don't want to lose father. And we don't want to lose grandfather and grandmother. And the list goes on, of course. How many of you are having that conversation with people? Don't talk about the pulmonary disease. Talk about the loss. I want people to cry. I'm going for tears here. Because, of course, families are pushing us all, aren't they? Families are pushing me as well. But when I start to get into that, some, not all, some of the families will say, no, mother would never want to live like this. Yes, I agree. And I want people to be comfortable with their choices as family, because of course, family are going to live on with the memories. And there's a group of families in my world as well, just like yours, who say, I don't really care. You got to do it. And we do it. And 10%, I'm going to say, of my patients have died in the intensive care unit with a tube in every single orifice. And I'm providing them and the families with palliative care. I'm still doing the morphine to make sure they're not breathless. I'm looking after their skins. I'm helping the families walk the walk of this patient isn't doing well, are they? Hopefully getting the families to a spot where they can see that. Not always. So this is very challenging. I get it. And I think back to the fundamental question is, what's the context? How much disease does this person really have? And we know with multi-system organ failure, whatever it is, an assault on top of that, like a pneumonia, people don't do well.
So just adding to that, Dr. Ferris, and for Dr. Shah Jahan, there are a lot of research that has said that when we see patients in the ICU, the connection we have is during the acute phase. Like Dr. Frank said, what happens to them when they go home? Is the focus on quantity of life or quality of life? the research that has suggested that patients admitted in the acute in a facility for an acute exacerbation of, say, COPD, we have research now to suggest that close to 60 to 70% of the patients keep coming back for readmission. And at the end of 5 years, probably only 25% of them are alive. So are we selecting patients in the ICU appropriately? For example, I don't know if Pallium has already shared that gold standard framework and the Blue Maple document. You know, as a doctor with your great experience and seeing and looking after COPD patients, when you have an elderly with multiple comorbidities on long-term oxygen therapy with a failing lung function test and or maybe even requiring NIV, this candidate is not going to do well in the ICU. Therefore, an early integration of palliative care will avoid this discussion in the ICU. This patient would have had these talks and time to process and analyze, to think that I don't want to be in the situation where I'm outside the ICU and now people are discussing whether I should be on the venti or not. It's too late. That is why this whole series we are having is to have an early integration, earlier conversation. And yes, if your patient has reached the ICU, then also you can do a time-tested trial. Put your patients on venti, see the response, regroup, review, and say, yes, now it is time to withdraw because these patients are not doing well. In a country where two things: one, patient is paying out of pocket. That doesn't mean he continues to pay out of pocket because he can afford it, because the suffering is something that is not budgeted. And secondly, also in a limited resource country, we have a 40-year-old who can be saved with that ventilator and go back to good quality life. Are we doing justice by putting an 85-year-old COPD who's not doing well? So, I know in a private practice it is different, but we have to still do ethical practice based on 4 pillars of medical ethics. So a lot of discussion can go on, but if you start talking to appropriate COPD candidates much before they reach the ICU door or the casualty door, we will not be in this situation where we are putting patients on ventilator or removing patients on ventilator who need not be in the ICU in the first place. I'm happy to share some articles about outcome of intubating or offering aggressive medical therapies in both patients of advanced COPDs and ILDs. The outcome is poor. Knowing that, should we be going down that line? Yes, they do come back, but like Dr. Ferris says, is it survival by quality or survival equal to quantity? And all our research papers actually see endpoint as survival. Very few research papers focus on quality of life of the patient post ICU discharge. That is also something you and me didn't see when we are an acute intensivist or a pulmonologist. We don't know what happens to the patient when he goes home. We don't know how much more burden we have caused by the ICU admission. That is something we are oblivious, and therefore we say, I sent him home alive and I have done my job. So I was right in intubating the patient. Where the patient can walk, patient can eat, self-care. Is he happy? Because post-ICU, they do go through what we've seen post-traumatic stress disorders, because an ICU stay can be extremely difficult for patients and caregivers. I hope that was, satisfactory to you, Dr. Shahjahan. We can obviously take this discussion offline also, and I will be happy to supply all the relevant articles about what happens to patients when you put them in ICU, when they're not supposed to be there in the first place. So we need to start thinking about the selection of patients for ICU also. Not everybody went for ICU. Yes, Dr. Frank.
Well, I think it's this early conversation. Healthcare is all about giving people the capacity to live the lives they want to live. It's about being able to enjoy things. It's about being able to do things. At a certain point, people become dependent. People are not able to do the things they want to do. And if we've had a conversation with them, they'll say, I don't like life like this at all. Now, the family may be struggling because, of course, they don't want mother to die. They don't want to be without mother. Are we having those honest conversations with people in advance? With COPD, we have months to years to do that. And I'm not for a second saying we should let the patient go prematurely. In fact, if I was talking with you about COPD, I'd be saying, come on, use the opioids sooner. Opioids, the breathlessness impacts prognosis, it shortens it. Let's use the opioids appropriately. I've got patients who live for months when I was thinking they were going to die when I first saw them. So I want the best of care, but those patients lived for months and they were able to enjoy things. Now you're getting the patient who's now in the ICU. Why did they end up there in the first place? Were they heading towards that? Could you see that they were, in fact, debilitated enough? Can you predict that they're not going to do well? And what would they say? Because again, back to I love what Dr. Rajam says. It's not about surviving the ICU experience and thanks very much, go home. It's about you and I have to prepare people for their lives back at home. Are they living the life they want to live? Or did we just put them through an experience which was horrible? And I don't know whether you've ever had a delirium or bad pain or shortness of breath. These are very fearful experiences for people. And this sort of pending, oh my goodness, if this is going to happen to me, I don't want to be like that. Let's find out about it. Let's see what people's perspectives are. You know, being dependent, needing constant care, bankrupting a family, and I want to put bankruptcy on the table as well, because that's real. I don't want to bankrupt my family. And if we talk about it in advance, patients will say, I don't want to be a burden to my family. I want my family to be able to go on. But why aren't we talking about this? Because usually we're uncomfortable with it. And it goes back to our learning the effective communication skills. I am completely with you, Rajam. It's this conversation when we see the COPD, the interstitial lung disease is progressing. It's beginning to say, let's talk about the future here. It's a hard conversation.
So I also think there's another question, but I also think, Dr. Frank, non-cancer diagnosis is not appreciated or perceived as life-limiting. And a lot of it also is the physician's onus of not sitting down and explaining the trajectory of the illness. Because if you diagnose a patient to have lung cancer, he automatically starts thinking, how many days do I have to live? If you diagnose a patient to have COPD, he doesn't think that. And neither do we clarify saying, hello, I'm not treating your COPD. I'm treating the symptoms of the cough, of the bronchoconstriction, of, making you improve your stamina with your existing lung function. So it's a lot dependent on the onus of the physicians to foresee and foretell. And that needs time, right? So I think when you diagnose a patient of ILD, he's not going to say, doctor, when am I going to die? But if you say lung cancer, he'll say, please tell me how much time do I have? So it's not even perceived by the family as a life-limiting or a life-threatening condition. So a lot needs to be done by the physician.
Well, and when they say, how long do I have? Most people are not asking, when am I going to die? They're asking, how long do I have to do things that I like to be able to do?
Yeah.
You and I need to say,
live. Yeah.
Well, it's truly do things. And when people ask me that question, I say, that's a really important question. So many people ask me, why are you asking me that question? They've got stuff they want to do.
Yeah.
It's all about life. It's about living. It's about visiting with family. It's about being able to be and visit in a different part of the country. It's about being able to go to the movies. It's about being able to love the baby that's coming. It's to get to the graduation. It's this, that, the other. It's events. It's activities. That's what prognosis is. The question is all about.
True.
So take it to that next step.
There's one more question by Dr. Suresh Kumar. Sorry, and I'll get back to you. What is the relationship between ketones and endorphins release?
I'm not quite sure I understand what that question's all about. Both of those
so
happen.
Dr. Suresh Kumar, do you want to explain?
Yes.
What were you intending to ask, please? Thank you. You can unmute and ask, please.
Yes, ma'am. Sir, it was excellent presentation. I wanted to know at the end of life, you have mentioned that ketones will be released. Ketones increase will cause release of endorphins. So how is that going to help the patient?
Oh, so the endorphins give people a bit of euphoria, and the ketones are actually anesthetic agents, some of them. And so people become actually quite comfortable if we allow those to occur. We can see that in many patients. Early in my career, I used to do ventilator withdrawal by terminal weaning. Now we do it by terminal extubation most of the time, although in COVID we did the weaning. And you see, as you turn down the settings, patients actually get quite euphoric from this experience. They don't suffer at all. And if I do it very carefully, it's the CO2 narcosis that ensues, as well as probably some endorphin and ketone release. Patients are quite comfortable. They don't really suffer if you watch them very closely. It's an interesting phenomenon. So I think, again, physiologically, we were designed, if we do this gently and slowly, we don't suffer. You see people actually get somewhat euphoric. I think where the suffering comes, maybe the things we do to people, so I think we need to be careful about that. But the suffering also comes when we don't allow these natural processes to ensue, because sometimes our aggressiveness is not allowing those to occur.
I interrupted somebody when I was asking Dr.
Yeah,
Sush's question.
So
Can you
that-
please ask the question now?
It is not a question, it is a comment actually. You said about that is not the family issue alone. The neighbors involved, the society involved, the death in the house is not accepted even nowadays. Even the authorities, why the patient is died in the house, why all hospital deaths are okay, but the death in the house is not accepted, even in the moribund patient. That is the issue. So that the family member is forced to take the patient to hospital many a time. The situation in India, especially in Kerala, I should say, no house death is accepted. So that is also an issue.
I
Right.
am surprised to say that in Kerala, you're saying it because it is the place with probably the best place in the country to die because of the palliative care there. Having said that, there is no problem admitting the patient to hospital. But why should the patient go to get aggressive, futile medical treatment? So often I tell my patients, please bring the patient to hospital, but offer palliative care in the hospital. Why should the patient suffer? Yes, place of death makes a difference. If patients have desired and wish to die at home, then taking them to hospital, according to me, is wrong, because tomorrow it's going to be my turn and I will hate it if somebody does to me something I don't want to happen to me. Second thing, if the patient has not expressed any particular desire, or you have not asked the patient and relatives are not coping at home, please admit the patient. But admitting the patient in the hospital doesn't mean it's a conveyor belt and patient lands on the ventilator. Admitting patient in the hospital, you're allowed to take a negative consent, saying, please do not escalate, do not intubate, do not admit to ICU, offer maximum comfort in the wards. Patient comfort and dignity should not be compromised irrespective of where he's dying. So if you want to keep the neighbor's mouth shut and the community's mouth shut, admit him. But that also means you offer palliative care, because you can offer palliative care from OPD, home, casualty, ward, ICU. It doesn't have barriers of where you can offer palliative care. Dr. Frank, you would like to add to that?
Well, I think what you're highlighting is, for some people, dying at home is unacceptable for a variety of reasons. I am also surprised because I've been to Kerala and I've been to homes where people are dying at home. I've seen it. It was many years ago. So I'm surprised you're saying it is Kerala, but your experience is your experience. This is why we develop, within the context of hospitals, if we have a lot of people dying, we develop particular units within hospitals where, if that's where people come by choice, then we have palliative care units. And the staff there understand how to provide the care that is focused on comfort and making sure the person dies safely, if I can put it in that terms. it takes the doctor in advance to have prepared everybody, because what you don't want is a family in that setting who are not prepared for that setting, now creating chaos. So it's this sort of advanced work. It's perfect, as Dr. Rajan says, it's perfectly fine for people to die in hospital. We just need to make sure they get it right. And there will be families who will say, I am not going to look after the person at home. So we have to prepare the bed and the setting. And do you do it in a hospital, or do you do it in a setting as we have buildings which are hospices, which are designed for this kind of care, and they have full medical staff, and they can provide all the technology. It doesn't need to be that complex, but they can do infusions and they can administer the medications. So again, it's community by community. It's a choice of how we set this up. And those of us who learn to do this, I'm an oncologist by background. When I first started, this wasn't happening very much at all. But I've spent my career focused on making sure this was available in many different settings and that people know how to do it. So if it's not happening in your community, maybe you become the advocate for change.
Excellent.
I always said I spent 35 years preparing for my own future, because you and I will get the care that's available in our community. And if you cannot get the kind of care that you want, you better change it, because otherwise you're going to be admitted to the hospital, go through casualty, you'll be intubated, and you'll die in the intensive care unit. Is that what you want? And I'm looking at Dr. Sajad, who just asked the question. Is that what you want?
Dr. Frank is asking you, Dr. Shahjahan.
It's a difficult question. Actually, it's difficult area. So it's I don't have any answer right now. That is the issue. I have to think about that, because
I do want you to think about it. I want everybody on this call to think about it and reflect, because this is about us. Don't worry about them. This is about what we're going to get for our care. And we are all going to die. What do you want it to look like? And your mother's going to die, and your father's going to die, and your spouse is going to die, and your children are going to die. So it's not just about them, it's about us. And you will get the care provided by people that you teach and train.
Yeah.
What do you want? It is a difficult question. I agree.
Absolutely, it is a truth. It's a bitter truth, but the answers are complex.
Right. But if you can't be the person you are today, how much debility and dependence do you want to endure before you say, I don't want to be like this?
Yeah. It is not easy. And I think it is a thought-provoking point to end this discussion. And it's important when Dr. Frank says that all of us need to think of our own mortality. It is probably the only truth in life. Rest, everything is not guaranteed. This is the only guarantee in life. And we really need to sit and think. So if we get comfortable with our mortality, it gets easier to talk to patients about their deaths. And it's another thing which I've noticed is in India, we very often struggle to use the word death with patients. We say anything can happen, an event might occur, or something uneventful might happen. We will avoid using the word death. And we really need to get comfortable with that. And that can happen only when we start thinking of our own mortality, because like I said, it is the only truth in life. This topic can be very heavy and overwhelming, but it's a request that all of you think and understand the scientific logic when we put in that oxygen cannula, when we put in that extra fluid, when we, just give the patient one shot, especially actively dying. We have seen so often that patients are given one shot of dialysis, or put a peg just before death. It just doesn't make sense. We really need to think what value addition we are doing to our patient. How are we improving his quality of life? Is it in our patient's best interest? You ask that question, and then you know what to do and not to do. With that, thank you very much, Dr. Frank. Always lovely to hear from you. I hope to see you sometime soon in Bombay. And thank you to all the participants for coming after a long day's work and almost towards the end of the week, because we have our sessions only on Thursdays. And over to you, Rajalakshmi, for the feedback. Thank you again to all of you. Have a good evening and good day to you, Dr. Frank.
Namaste to you and a great day to you. Rest you well. Namaste.
Thank you. Bye-bye.
Namaste, sir. Thank you all for joining us today. We have shared the feedback link. Give it a minute, do it, then only leave the meeting. Thank you, Dr. Frank, for the excellent session and Dr. Rajan for the excellent facilitation. We'll see you next Thursday with another topic. Till then, bye. Thank you.
Bye.